you have a patient who is under like chronic care, like HIV or TB, antenatal, postnatal, or a child who is coming for immunization, would ideally they need to have their patient cards printed so that in case they are coming for, they decide to change any facility they are on, it becomes much easier for any health worker to manage the patient. So, for example, if you have an HIV patient who has been under care for 5 years and has, for example, maybe changed regimens for about maybe 3 times, you cannot, it becomes very difficult to manage that patient. But when you have that card, you can be able to manage that patient who has that record on a paper. So for now, we shall only try to provide the medical form 5 and the patient card, but for the registers and the reports, that is something which we should forget for now, because most of you are currently aware of the financing landscape. Most of the funding that was being provided to print these HMI tools is no longer available. So to go quickly on the progress, the approach which we had taken initially was to try, we trained a national team, and this national team was facilitated to go and conduct the regional trainings. The regional training were mainly the biostat, HMIS focal person, whom we trained at a regional level, and then these were later facilitated to go and do the last mile training. But we have observed that over time, we are realizing there are a number of capacity gaps on the number of functionalities when it comes to using the system. But also the system has gone through some number of upgrades within this very short time to make sure that we improve the system. So previously, the system was a bit slow. It would go off at some time, but also some gadgets we are not, we are becoming slower when you use the system. So we have done those upgrades. So we thought that we needed to continue to have one-on-one in these webinars so that we can continue to have this capacity building being done on different functionalities on the system so that we can continue to improve. So these webinars are going to continue this week and also other following week until we are very conversant that you have all been trained, but also we shall have a mechanism on how we can continue to train other staff who will come on board if most of you assume you are other laws. So we've noted that a number of facilities have used the system inconsistently. One of them, of course, being the capacity gaps that they are highlighting. Others were saying the issue of the internet. And since then, the internet has been provided for free, what we call a whitelisting. You can be able to type in your this other website into any system, either a phone or a tablet or a computer, and it will be available for you for free without internet. So that is also another progress on our end. But the point was that we've observed that some facilities are inconsistently using the system. We now so far have about 1,860 plus that are using the system consistently, meaning that you are using the system every day, and we see all the transactions, all the patients that you've been able to see. But we've been seeing others, we also be able to see others are using for a couple of days, then they stop using the system. And so that's why we are coming up with these are the weekly webinars so that we can improve your capacity. But also the Ministry of Health has also mobilized a number of tablets. So we are going to be able to add on the tablets which we had also previously issued so that we can now at least every service point has got a tablet for us to be able to see the patients, manage them well, but also be able to to report, to be able to report in time. So, but also you remember we have regional meetings every week. So you will ask your biostatisticians to be able to share with you those regional links where we also are able now to be able to have other webinars on some of the specific aspects which will be emerging from different regions. Here, we may not be able to have a comprehensive Q&A. We will try to spend most of the time to answer the questions, but you realize when you are in your respective regions, you can be able to have a very comprehensive discussion because the audience there is not as big as the audience that we have here on this national webinar. So I now submit the rest of other concerns. We shall be able to address them as they emerge, but continue to share and have these discussions with your other team members. Thank you.
Yeah, thank you very much, Dr. Andrew, for those opening remarks. So, colleagues, on the call, we have 229 participants, but we still say this is a small number. And our target is to use this platform, like Dr. Andrew has said, to try and reach out to as many people as possible. So let's saturate the link and make sure that every health worker is on call. So it is open for everyone. There is no scope. Let everyone be on board so that they get first-hand information and we learn together. Yeah, so that said, allow me now to invite Fatuma, our lead facilitator this afternoon. Fatuma, over to you. Take us through, and then we'll have like 30 minutes of non-stop, uninterrupted session. After the 30 minutes, then we can open up. So this purpose of the second phase of the webinar, we are largely interested in hearing out the users want to hear from you and be able to answer to your questions. Yeah, so the rest of you, as you wait for an opportunity to speak, you can write in the Q&A. The teams here will be answering in the Q&A. Yes, Fatima, over to you.
Thank you, Ben. Good afternoon, everyone. Welcome to this webinar. I'll be taking you through the ART, or the HIV section. So I know that last week we went through the login and all, how to register clients, and also went through the different sections of the eRegister. So today we are going to still take ourselves through, but I think I'll not go through the registration. So this is our interface, how the eRegister looks like. I'm in the customization instance or the testing.
Fatuma?
Yes, please.
I'm requesting kindly you go through the registration. You may not take a lot of time there because we assume that every webinar we get new people coming in.
Okay, no problem. So this is this is a testing, or it is a training instance. So this is how it looks like. So when you log on to your eRegisters interface, of course, it will have an interface which is different from this one. But of course, the login will come in, and then you log in your credentials as provided to you by the Biostat. So we expect that for each of the facilities, we have we have one credential for each of the health worker. We don't have one credential for the entire health facility. I think that needs to be clear, because in some of our districts, we have found that biostats are creating one credential.
Farida, sorry, Fatuma, if you're sharing your screen, we can't see it. Kindly share your screen.
Okay, let me share. Need to share. Yes, so can you see my screen now?
Yes, we can now see your screen. Proceed.
Okay. So we can log into our accounts. And the expectation is that each account, each facility health worker has a credential for that facility, not a health facility having one credential across all health workers. I think that needs to come out clearly so that whoever has not created accounts for each of the health workers within a facility, we need to do that. So when I log on, this is the interface that we get. It has, and one of the things that we have been advising the users is that you need to look at the name of the facility. It must be your facility name, because what happens sometimes we get into the customization instance or the training instance and we start logging in. Sometimes people enter data in there and they think they are entering facility level data, and yet we are entering data in a different platform. So let's be vigilant and look out for this. We look at the facility. So your facility must be the facility where you belong. Then the other thing that we have been advising is about the pulling of data. So as we come to work on that day, we need to pull data. So we need to be pulling our data. So pulling data means that you're pulling data from the server onto your machine where you're going to work from. So in case you had any data that has been entered by other people, it should also come to your machine so that it is you have the whole health facility database. Then the sync metadata means that in case there are any new developments or any changes to the system, this is where we press, so that when you press on sync metadata, it means that you're actually pulling all the other the new developments on the system, so that you also have the same experience as the rest of the other users. Then the push data is that at the end of it all, we need to push data. The pushing of the data means that we are actually storing our data to the server, or we are making sure that whoever is on that platform, as we enter data within the health facility, when I push the data that I've entered on my machine, then someone else who is in the same facility, when they pull that data, they should be able to have it on their own machine. Then we have the errors tab here. This errors tab is one of the new developments that were put into the eRegister. So in case you have any failed records, any errors in the data entry that you have made, the errors will be popping up here and you'll have a number here. And once you click here, then you should be able to, it will be able to display the errors that are there. And then when you click on each of those errors, they will take you to the data element and to the person or to the client where that error is coming from. Then the verify reports, this is where we generate our reports. We click here, we generate reports, we verify them, and then we submit them into the EHMIS. So now to get from the interface of the eRegister, we also have the search window. This is where we search for clients in case someone had already come into the facility and we need to just continue with them, especially maybe for those that are having chronic care. We search for them from here by these different variables, and we need to be very careful as we search. We know that sometimes we search the first name. Someone enters the surname into the first name and they search, and then they say, I can't find my patient. So we need to see the headers of each of these search dimensions so that we are entering the right information, and then we do the search here. So now we are going to get into registration. So as we register clients, the clients will add on to the total clients that we have entered into the system. And then it will also be able to give us a total registry for that day. How many clients have been entered into the system of that facility in that day, regardless of the service entry point. So if we have entered 10 people in maternity, we have entered 3 people in OPD, we have entered 5 at the ART clinic. So here we shall have 18 registered clients today, because they are the total clients that we have entered as a health facility. So we need to be pushing the data and also pulling the data all the time that we are using the system. So to register a client, we have this tab here where which is reading register new client. So you click on it. When you click on it, it will bring for you an interface where you do the registration of the biodata of the client. So the first variable that we have here is the registration date. So when you click in here, when you click into this space here, it will bring for you the calendar. So you can be able to register a client retrospectively. You can be able to enter the client on that same day. So if you are doing registration in the previous times, you can even enter people of July. So you just keep moving the arrows as we see them here. So then it takes you to the previous months and then the previous years if you wanted to enter data for the other years as well. So for us to get back to registration, so you can enter the date of today, or someone can actually click on this today, and then it will still bring the date of today. Then we have the surname of the client. I can put and get any. So I can put maybe might want to, let me put a woman there and put Nantongo Maria as the first name. Then we also select the sex of the client, and this client is female. Then when it reaches the date of birth, this is the date of birth. So the date of birth, it gives us to, when you click here, you can be able to type the date of birth, but you can also use the calendar. When you click on this, there's this icon of the calendar here, so that someone can maneuver through the calendar. But what I know is that one of the things and the experiences that the health workers have is that most of our clients say they claim not to know their date of birth. So what we have been doing, we have been entering the years in here. And once you enter the years of the client, let me say she's 23. Once you enter 23 years, the date will be automatically generated based on the day of registration. But then we can also use the calendar. I can remove this. So we can use the calendar as well. So when you use the calendar, we can be able to say maybe this person was born in, so when you want to change the years, like we have them here, you can click on 2026. You click on 2026, then it will display the different years in a number of around 12. So you can go back. You can use these arrows to go back. So you keep getting back there till you see the year when someone was born, and then you click on it. So when I click 2002, then it brings the months. So these are the months of the year. So you also click on the month when that person was born. So I can click May. And once I click on May, so it brings for me the calendar for May 2002. You can see it has already auto-selected 26th because today is 26th. So you can actually change that to the date when someone was born. So I can say 14th. When I click on 14th, to be able to get for me the date in there, and then it will auto-calculate for me the years when someone was born, the number of months that someone has as of that day of registration, and the number of days the person has as on that registration. How old is that person as of the date of registration? Then we go ahead to register the client category. We have 3 categories. We have national, foreigner, and refugee, and this is how this appears in the different registers that we are using. So you can click on national. And then we have the NINI number. So you can, if someone has come with their NINI, we should be able to enter their NINI in there. And then we put 02. You can click JL. So you put the NINI number of the client. And then this client ID is a number that has not been agreed upon nationally. But I know some health facilities have been generating their own numbers so that they can be able to identify their clients within the health facility. Then if the client has a phone number, we should be able to enter the phone number as appropriate. So I can say this is the phone number of the client. So it should have the appropriate digits is and I can add a 0 here. Yeah, I know that previously the system has been telling us to enter 256 as a code for the phone number, but this is something that has been reversed. So you can be able to enter someone's phone number as they give it to us. So this is the phone number. So it can allow even when you do not put the 256 and then the 7. Then we have the alternative number. Most of us have maybe like 2 numbers or 3 numbers. So if someone has an alternative number from the one that you have already registered in here, then you should be able to also input that phone number. Then we have the marital status. It's a drop down, so you should be able to select accordingly. So let me say this lady is married. And then we have the occupation. The occupation is a long list, so you should be able to select as appropriately. And then we have other. So other will take care of those that are not part of the categories that are already listed in this list. So if this is an subsistence farmer or subsistence whatever peasant farmer, we can be able to select accordingly. So you can actually put maybe agriculture. Sorry. So when you put Greek, to be able to give you the different things to do with farming, and then we should be able to select appropriately. So I'll select Nantongo to be a subsistence agriculture worker. And then for the village's address of where the client comes from, so we can select. So this is a long list. I know that some people have been giving feedback on this list, but one of the way we can maneuver through this, let me say this client lives in Nalumunye like I do. So you can start typing Nalumunye. So as you type the village, it gets to sieve out for you that village, and then you should be able to select appropriately. So this is my village, so I can select it. And once I select it, it will auto populate the parish, the sub-county, as well as the district where the client is coming from. So next of kin details, these are details that are required in case we need a follow-up for the client, and we need to really get these from the client. So if the client has a next of kin, let me say, I will say, can put the name that the client gives us. So I can say Gonasa Musa. And then the contact of the next of kin. If the next of kin also has a contact, you should also be able to enter the next of kin contact as well. So let me see if I entered more. Sorry. So if you enter more than the digits that a phone number should have, you find that, of course, this is going to tell us that actually, I think for the next of kin, this still appears, the 256 number. So you should be able to enter that appropriately. And then the relationship. What does the client call this person who is the next of kin that we are registering as part of the biodata of this client? Is it a spouse? Is it a sibling? Is it a parent? Is it an auntie? Who is that person? So maybe we shall say is a spouse. And then we have these two tabs highlighted here. We have register client, and then we have register client and add another. So this register client means that you're going to register this client, and then you proceed with the service provision of this client. So register client and add another, it means that you're going to just do registration for this client and then register another client. So once I say register client and add another, it will save this client registration details, and then it will give me a fresh window for me to be able to register another client. So we are going to proceed to providing services to this client. We are going to proceed with this client, so we shall click on register client. So when you click on register client, it will bring for us this other display. But one of the things that we need to be mindful of is that here we have the person profile. So this is what we have been having for registration. So when you say edit, it will take you back to the registration window. So in case you forgot something, then you should be able to update it here, and then you save the client after providing or after entry of whatever new variable that you wanted to enter or whatever that you wanted to edit accordingly. Then for you to be able to see the client profile or to scroll through or to hover through, there's this other drop down or this arrow that looks down here. So for you to be able to okay, here it is expanded, but now we need to take it back. So you just click there and then it will close it up. But if you want to see the client detail, then you still click on that arrow and then it will display what is in there in the person profile. Then when it gives us this window, this is the window where we do service provision. It has this new tab here. It says add new visit. So adding a new visit is that you're actually entering what are you going to provide a service, like what has the client come for on that visit. That's why we are saying add a new visit. So when you click on add new visit, it will bring us this other new interface, and the new interface has the different details. And one of the things that have been made into this system and customized in there are these details that we have in this panel. So we have the triage details, we have the screening, we have the laboratory tests, as well as the medication and supplies that have been provided to the client. But some of the things to note is that we have variables where, or data elements where we have these stars. These are a must enter, but this does not mean that where we do not have the stars, we do not enter that information. We need to be mindful that all the information that we have in here is information that is good for reporting as well as patient management. So we need to ensure that we complete all that we have done for this client on that visit. And then we have the save window, the saving button down here. So you can see that since I have not entered anything, the save visit button is inactive, and it will only be activated when I select a few things, as we will see as we present. So visit date, we include the visit date here. When you click here, of course, it will give us the calendar, and then we select the date. Then from there, we select the service type. So one of the things that we need to note about the service type is that all these are registers that we have been using in the different health facilities that we have. These are the different registers. So these registers have been customized into service. We have put them here as service type, but just know that for each of these is a register. So once you click on it, let me say when I click on pre-art, it will just get down here. And also when I click on ART, it will also be displayed onto here, because I'm going to take us through the ART module. So from there, once you can see that already our save visit is also not activated, because previously what was happening is that we used to just click on the service type, enter a few things, and then we save the client. At the end of that day, we have not provided services to the client, but the system was able to let us save for that client. So when we get into the triage detail, we have referral in, it's a yes or no. So we need to click on this, because we know that on our OPD report or in the different reports, we have where we have referral ins, number of referrals in and out of the facility. So this is where we get the data. So once you have not clicked a yes on that referral that you have received, do not expect that it will be generated in the final report that you will generate at the end of the week or at the end of the month or at the end of the reporting period. So referral in, we shall say no. Transfer in, say yes or no. So this is not a referral in. Then weight of the client on that visit, we should be able to enter the weight as we have measured from the weighing scale. Then if you have a height board, then we should also be able to enter the height of this client. Temperature, if you have done the temperature, then we should be able to enter the temperature of this client. Let me say is 37. Then the oxygen levels, we should be able to enter if we have had these measurements done. The respiratory rate, if we have done a respiratory rate, then we should be able to enter the value here. The pulse rate, we should be able to enter the pulse rate as measured from the pulse machine. And then for BP, we have both systolic and diastolic measurements. So you should be able to enter for this client. So let me say that systolic is 125. and then the diastolic is maybe 89. And then, of course, it is asking what is the blood pressure status. So you can see here, this is normal. So you should be able to enter normal here. And then blood glucose, if we have done this test, then we should be able to enter whatever. We need to click on whatever glucose test that we have done. If I say random, it will actually open up and it will ask me which unit measure of random blood sugar have you done. And then I should be able to maybe say, I should be able to select appropriately. And then it is asking for the result. So once you click on any of these, you should be able to have results, and then you should be able to enter the results in there. Let me just put anything there. And some of these things have been auto-generated by the system because they also help in patient management. So you can see that when I entered 10, it said that this is normal blood sugar. So if you entered another variable, let me say 17, it is still saying it's normal. So when I click 89, oh God. Okay, so it still says that that is normal. Then we have the pregnancy status. So we have pregnant, we have not pregnant, no breastfeeding. We have breastfeeding, and then we have pregnant as well as lactating, because we know that some women come to the facility while they are lactating, but then they have also become pregnant, or they were pregnant but still breastfeeding their babies. So we select this appropriately based on the situation of the client. If this client was a male, so this pregnant status would not have appeared. So let me say this client is not breastfeeding, is not pregnant. Then we have nutrition assessment. Nutrition assessment, we have BMI, we also have the MWAC. So once you select one of them, then the results will come through. So once I select BMI, because I've already entered the weight and the height, so the system is already generating for me the BMI measurement for that client. So if I selected MWAC in there, if I selected MWAC, then it will also ask for the MWAC measurements. So when I say 24, it will still auto-generate for me that, yes, this adult lady is in green and the nutrition status is normal. So we also have additional tests that we can do. We have the appetite test. If you have done the appetite test, then you should also be able to select according. If you have done it, then you say yes. If you have not done it, then you say not done. Then the hips waist ratio, the waist hip ratio. So this is looking at the how much fat is getting into the waist and how much maybe food. Let me just use the layman's language. How much food is getting into the waist and how much food is getting into the hips. So this is measured, and then they should be able to put the ratios here. There are those that are normal. So once it is beyond maybe 7 or something, these are things that have been added by the program. So they have cutoffs, and the teams that are down there, we expect that the health facility team should be able to know what they are doing, and they should be able to enter the results appropriately. So in case this client is an emergency case, it's a yes or no. So you should be able to select accordingly. So this is not an emergency, it's a no. Alcohol use, we know that part of our registers, let me say the OPD register had all these in there. It had alcohol use, it had tobacco use, it had subsistence use. All this was part of the OPD register that has been replaced by the eRegister. So you should be able to select appropriately. So if there's no exposure to any of these, then we select no. And in case there is a yes of any sort, then you can also select yes. Then any family history of NCDs, once you say yes, then it will ask if yes, which NCD does this person have history on. It's a long list here. You should be able to select appropriately, and some of these are really good for patient management. So you should be able to select appropriately. Maybe I can say hypertension 1 and 2. And this is a multi-select. So you can select as many conditions, as any NCDs as this person is exposed to, or as if a part of their family history. So you can select as many as you can. And still to notice that this is just hypothetical. It is not, we are just entering a dummy client. Then feeling or anxiety on age. So we have a drop down. So you should be able to also select appropriately based on what we have, based on our assessment of the patient. Then you should be able to select appropriately. And then not being able to stop or control worrying, it is still also a drop down. So you should be able to select appropriately based on our observation with the client, but also our assessment of the client. Then feeling down, depressed, or hopeless, then it is also a drop down. So you should be able to also select appropriately as also assessed the client. Little interest or pleasure in doing things, it is also a drop down. So you should also be able to select appropriately as we do an assessment for that client. Whether the client is on long-term medication, it's a yes or no, so you should be able to select. If you select yes, it's also good for patient management so that someone knows that actually this client is already exposed to some medication. As they give any other medication, they should also be put into consideration the other medication that someone is on. Then physical activity, 30 minutes a day, 5 days a week. So this is a yes or no if anyone can do physical activity. So you can say yes. And then you can see that age at visit is something that is already auto-populated based on what we entered at the beginning in registration. And also we need to know that this age is also very important because this is the age that we use to generate the report at the end of the month or at the end of the reporting period. Then we go to the screening. The screening, most of the things that we used to have in the different registers for
Fatuma?
screening. Yes, please.
Yeah, we need to go over that very quickly so that we don't be caught up by time.
Yeah, that's why I didn't want to get through this. Okay, so here we have screening for each of these are different conditions that we used to screen for in the different registers. They have all been put in here, and you can see that the responses are yes or no. And as you select a yes, it will still open up other different things for you to be able to enter for that client. So it's I'll select no for each of these. So once you select, you can say screened for TB, yes. Is it static? You can see that once you say yes, it opens up other data elements to do with what you have screened. So it's not about saying a yes or no, like we have been doing in the HIV blue card. So it's about you have provided a service, kindly detail what you have provided for that service. And then is it at the facility static? You can select static. Which method? Is it asymptomatic screening? Is it X-ray? Is it CRP? So you should be able to select appropriately once. And you can select, this is a multi-select. So you can do symptomatic, you can do X-ray, whatever that you have done. And once you say symptomatic, you can see it has also opened for us that this client has symptoms and signs of TB. So you can say has no symptoms. Then we have screened for leprosy. No, we have not screened this person for leprosy, and then screened for NCDs. Yes, and then it can ask you which NCDs have you screened for, and then you should be able to select this appropriately. And this is also a multi-select. So once you select, then it also asks for additional information of what you have done. So let's just be careful. Let's not just be selecting as we wish. So let's select appropriately as we have provided the service. So I'll say no, but just be mindful that as you say yes, it will open for you additional things in there. You can see for sickle cell, it is asking why haven't you screened that person for sickle cells? And then you should be able to answer appropriately. So you can say inadequate facility staff. Maybe you don't have staff that have the knowledge to screen for leprosy. For sickle cell, sorry. So PrEP, we have not screened. Then we go into our service type. So we know that this is our ART client. We shall say this is a new client, so we shall get to pre-ART. We all know that as a program, we start from pre-ART. So this is our new client, so we shall say this visit is a new visit. If someone came back and they are coming back for pre-ART, we shall say that person is a revisit. But for now, we are registering this client afresh or freshly in our facility. So we have new, referral in, transfer in, no, because it's a new client, and then date of enrollment is today. And then pregnancy status, we have already said this patient is not pregnant, is not lactating. And then we have also done the MWAC as well. So this client has a normal MWAC. And all that we have done is nutrition counseling. Please keep being normal. And then we have WHO clinical staging. We should be able to stage the client appropriately as the client appears to us or as we have assessed as the clinical team, then we should be able to select appropriately. And then if you have done a CD4, a baseline CD4, then we should be able to also enter the data for that CD4. Let me say this client is we have done a CD4 and this client has a CD4 of maybe 300. Eligible for CPT, yes. And then once we say eligible for CPT, then they're asking for the CPT start date, which is today when we have gotten this client, and then this client has been provided with CPT. And then TB test type, if this client has, we have subjected them to any TB screening, then we should be able to select appropriately. But here we are asking for the TB screening status. So we shall say this client had no signs and symptoms as already seen in the screening window. And then follow up, this client has been moved to ART. So you see, if the client remains active on pre-ART, we shall select active. If the client gets lost on the program while they are still in the pre-ART, then we shall also still select all these appropriately. And once you select active, then it will be able to count this client as active in the our 106A. But once we move this client to ART, it means that it will count this client as part of the new enrollments onto the ART, onto the program, newly enrolled in the HIV program, but will be new on ART, in the ART program. So once we have moved this client to ART, so we shall click on ART, transfer in, say yes or no. So we click no because you have already said that this client is not transfer in. Then visit type, this client is our new client, and then we give the ART number as we have also been giving it out. So you can say this is 456. Pregnancy status, not pregnant. Nutrition, normal. Malnutrition intervention, counseling. And then special category. If this client belongs to any special categories, then we should be able to select appropriately. But if we do not have any special category where this client belongs, then we shall leave it blank. Then ART start date, it is today. Then age at ART initiation, this is 24 years. And then we had our clinical stage as 1. Then our CD4 was 300, still our baseline CD4. And then eligible for CPT, yes. And then start date is yes, today. And then received CPT as yes. And then our TB status is no signs and symptoms. And then we have the model. So we have all these models as they appear in our different, in our blue card. So we should be able to select this. So I can say maybe this is a group managed by the health workers. Since this is a new client, we shall manage them here. They will be still here. Then if we have done any vaccination for this client for HPV, then we should be able to select appropriately. The client is not vaccinated, we still select not vaccinated. So we know that this is our woman. So it is asking for cervical cancer status. So we might, based on our assessment, this client, we can say maybe not applicable, but we can select based on our assessment and based on the results as indicated in the drop down. Then we know that part of our report, we have a DM screening, or we have a whole cascade for NCDs. So this has also been brought here. So we can say maybe this is a, So this is what we have here. So you can say this person is a normal blood sugar or has no signs and symptoms of DM. Then for hypertension status, we can say normal blood sugar, normal blood pressure. And then treatment line. This is the first time the client is appearing. They will be on first line. So we select first line. And then as we select first line, then we also have this drop down. Is it a new client? Is it a current client? So is it a client that we are maintaining on the same regimen? Is it a client that we are switching from one regimen to another, or we are substituting within the same line of treatment? So here, this is our new client because it is the first time that they're attending the clinic and is a newly diagnosed client. And then we have the regimen. Which regimen are we putting on this client? It's a drop down, so you should be able to select appropriately. I'll select TLE. I can select TLD, which is 1N. And then in case we have done TPT screening, we have initiated this person on TPT, then we should be able to select appropriately. All these are in here, and all these are variables where we report on in our 106. So you should be able to select appropriately. We can say maybe eligible, not initiated, and then eligible for viral load, of course not. And then we have all this is not all this is not applicable. So we cannot put viral load. This is the first time we are having this client. So all this is not applicable. But just to say that in case this was applicable, we have done a viral load. This is a dummy client. So we have done a viral load, and maybe it is 500. Then once you put 500, you can see that you're asking for the date when the viral load has been done. Maybe it has been done today. And already the system will auto-generate for us whether this person is a suppressed or non-suppressed client. And we all know that in case this client was non-suppressed, then we should be able to do a CD4. If we have been able to do a CD4 using the different mechanisms, then we should be able to put the CD4 results in here. And if the CD4 is below 200, let me say, already we had our CD4. Okay, the other one was at baseline. Let me say now it is follow on. Then we have a CD4 of 400. Of course, this client is suppressed, so we do not expect to be doing a CD4 for that client. So let me say if we had this client having a viral load of 200, so it will, of 1,200, then you can see that the system is able to generate for us that this client is non-suppressed. And then if we do a CD4, then the CD4 is also maybe below 200, then we should be able to go ahead and do the AHD assessment. We have the CRAG testing. If you have not done it, then you can say it has not been done. If you have done it and it is negative, you should be able to also select appropriately. Let me say it was maybe positive. And once we say positive, you can see that it is opening for us. If we have done a cryptococcal meningitis test, if we have done it, then we select the results. If you have not done it, then we say we have not done it. And if in case we have given any medication, then we should also be able to select the medication that we have provided to that client. Histoplasma test results. If you have done a histoplasma, we have all these results here in a radio button. So you should be able to select appropriately. If not done, then we say not done. If it is positive, then you should be able to select that it was done and it was positive. If it was negative, then also select that it was done, but it was negative. Then if you have provided any medication, then you can say yes if you have provided any medication, but you can also provide medication when someone is positive. So if once you have selected negative, then that means that this will not be applicable, so you should not be able to select anything there. Then if you have done any ASPR tests, and then we should be able to provide results. If not done, then we select not done. And if it was done and it was positive, then we have given some medication, then we say, yes, we have provided medication. If you have not provided medication, then you say, no, we have not provided the medication. And then we have HIV-DR test sample collection. If you have we have collected the sample for HDR, then we say yes, and then it is asking for the date when that HDR sample was collected. And then when the results return, then it is also asking, have the results returned to the facilitator? Say yes or no. If you have received results, then you say yes. And then we have the ART regimen status for HDR, for HIV, DR. We know that part of the report on the section of DR, we have all these, how many were switched, how many were maintained on the same regimen, all this. So we select appropriately. Maybe you have maintained the client on the same regimen. If you have done ISC for this client on that day, then you select that day, and then you also tell us the outcomes of the ISC. So we have, as we have done the assessment for this client based on all that we have done, so we should be able to conclude, did we identify any advanced disease for this client? If no advanced HIV disease, we select no advanced HIV disease. If we suspect anything, then we should also be able to select accordingly, as options have been provided here. Still, assessment for anxiety, depression, we know that this is part of our 105, our 106 report, so you should also be able to select what we have done. And if no signs and symptoms, it means that we have assessed the client but had no signs and symptoms. Alcohol, if you have also assessed no signs and symptoms, you should also be able to select appropriately. Then in case this person has come back to the facility and they have any ADR or side effects to any of the medication that they have been provided, then we should also be able to select accordingly. So whatever that the patient is presenting with, then we should be able to select what the patient is really telling us, what has brought or what they have as side effects as they swallow the medication. Then for TPT, still we are looking at whether the person is eligible for TPT. It's a yes or no. So if someone is eligible, then we say yes. If it's not eligible, then we say no. It's a drop down. Then we have HIV ART regimen, number of days dispensed. So you should be able to, for the drugs that we have given, the TLD that we have provided for this client, how many have we given? Maybe let me say this is a new client we have given for only half a month. Then we should put 15 days. And then any health packages that have been provided to this client, then it is a long list of a drop down. So you should be able to select whatever that we have provided for this client. Say maybe psychosocial support. And then OVC assessment, this applies for children below 20 years. So this is a client who is 24 years. So with that, we shall leave it as is. Then any advanced reaction grading. In case someone has come up with ADR effects, then we should be able to grade them. Are they mild? Is there, according to assessment, there's no ADR. Is it moderate? Is it severe? So we should be able to select from this selection. And you can see that as you select moderate, as you select mild, they are bringing whether we have been able to manage it accordingly. So it is asking what action has been taken. Is it managed locally, or you have referred someone for further management? So you can say maybe you have managed this locally, and then it is asking for the follow-up status. So you can see this is the follow-up status that we have. We have active. So once I say this client is active, it will ask for the next appointment date, and then I give the next appointment date in the future. But if once I say this client is lost to follow up, let me say I've transferred out the client, because that day I have the client, then it should be able to tell me what day have I transferred this client out, and then I also select the date accordingly. So I'll say my client is active, and then I'll select an appointment date in the future. I've given only 15 days of drugs, so I should be able to give, I should be able to give 15 or 14 days to come. 1, 2, 3, 4, 5, 6, 7, 8, 10. So I can tell this client to come back the following week, maybe on Monday or on Tuesday. So I give that next appointment. And once I do that, then I should be able to save a visit for that client. But as I continue with this client, maybe this client has had lab tests. So when I click on lab tests, it will show me a window for where we provide lab tests from, and it has an add button for the lab tests that we are providing for that client on that day. So once you say add lab tests, it will bring for us a window for the lab tests, and it is requesting for a lab number. We can put the lab number. This is an original sample. Then it asks sample origin. Is it collected from the facility or received from another facility through the sample hub collection or sample referral system? If it has been collected at the facility, they are also asking from which department. So they are also asking from which department have we collected this sample. So we can say chronic care clinic, and then we have the lab test. Maybe we have done a CD4 test, and then sample rejected, no, and then sample referred, no, and then absolute numbers. We said this client had 300, and then any lab notes for this client, then the lab person should be able to also summarize any lab notes that are really very important to the clinical team. And once you can see that it is telling me to save a lab test or save a lab test and add another. Save lab test, it means that this person had only one lab test to be conducted. So I'll just save this lab test and then it will take me to another window. But if I was having more than one lab test, then I can say save lab test and add another. So once I say add another, it opens up a fresh window for another lab test. So if we had maybe, let me say we did the CD4, we did viral load as well, then we should be able to add a new test. Then for medication, of course, for medicines and supplies, you click here and then you add medicines and supplies. And for any medication that you have prescribed, I know you prescribed TDF. Okay, let me select this. So how much has been prescribed? 15, that is what we prescribed. And then quantity dispensed, it's asking for how much we have also been able to dispense. They prescribed 15 and we have been able to also dispense 15. But you can see that once I have not yet input anything in there, sorry. Once I've not been able to input anything here, you can see that it is asking for the reason for not dispensing the quantity prescribed. So in case I put a different figure from what has been prescribed, then I need to give a reason. Why didn't I give the 15 that had been prescribed to the client? Was it because of a stock out? Or if clients are paying, is it that they were able to just afford the 10 tablets that I have given to that? So if we have prescribed 15, we have also given 15. So the other reason for not dispensing goes away. We know that as we prescribe this, we also have other medications that we provide on top of the ARVs. So in case you have provided additional, maybe Septrin or any other medication, then we should be able to save this medication, and then we add another, and then it will also bring for us a fresh window. So I'll say save medicines to give me that I've given. So if you can also still get here and add another. Let me say we give Septrin. Septrin. Yeah, so you have cotrimoxazole here of 960. Maybe you have also given 15 for the 15 days, and then we have also provided 15. So it says save, and then it will bring both medication. Didn't I? Okay, so it ran away. Cotrim. So when I select cotrimoxazole, I don't know why. Okay, yeah, then I can be able to save. Okay, so I have here my 2 medications that I've been able to prescribe to the client. I still have this other. We know that part of the HIV program, TB program, and also HIV testing, we know that we have contact tracing as part of the programs that we have in there. So once you select ART, to bring for us the contact tracing, to bring for us a contact tracing window for us to be able to input data if we have any clients for contact tracing. So if we are registering this client and we have been able to get additional information on the contacts of this client, then you click on contact tracing and then you add the contacts for this client Once you add contacts, of course, you can see that what is the contact type? Is it HIV? Is it TB? Is it leprosy? So we are dealing with HIV. So once you select HIV, then it will ask for the review date, which is today. Then contact encounter date, when the contact is the client that we have right now. So when are we, sorry. So this is a contact tracing for the client. So we have HIV in here, and then we are asking the category of the client. Is it an index client? Is it a social network client? So shall say this is an index client. So we select that one. And then we have the date of review. Then we input the date. And then we put the contact encounter date. So if we are having our contact today, then we shall select appropriately. Then they're asking for HIV status of the index. So if we have, because we are asking the client right now, if they know the HIV status of the client, then they should be able to select appropriately as the response that has been provided by the client. Child test already on ART, not okay, you can select any. Then any special category, if this client belongs to any special category, then we should be able to select appropriately. But if they do not belong anywhere, then we can leave that one blank. Then we have reasons why at risk, then we should be able to select appropriate. Is it because of their lifestyle? Is it physical presentation? Is it sexual history? Is it other reasons? Then we should be able to provide maybe sexual history. And then the contact name, what is the name of the contact? So you should be able to list the contacts for Nantongo. Let me see, we can start with our husband. Then the contact's age, maybe this is also 26. He's a male. The NINI number of the contact, if we have, then the contact number, 72. That is the contact of our index client. Then a relationship to the index. This is our husband. It's a household member. And then contact encounter by means. How can we contact or how have we contacted the contact of this client? Is it the means of contact? Is it a phone call? Will it be a home visit or other? So this client can still tell you how you can go about this, because sometimes the people that we are dealing with are very sensitive. So we need to get this information, maybe home visit or phone call or any other means that will be appropriate for contacting this client. And then in case we have contacted the client, then we need to give out the outcome of this client, and then we document it appropriately. So you can say maybe refused the test, and then history of contact of violence. So we know that in most cases, as we do contact tracing, we are also mindful of the violence of the contact. Sometimes we bring contact. So it depends on how we address this matter so that we do not bring up issues of violence. So any history of contact violence, so that's why we are asking for this, so that we intervene appropriately. So any history, you can say maybe no, and then case closure status. If you have closed this, then we should be able to also select appropriately. Maybe you can say, so you can select based on the service that you have provided. These are so many options that we can choose from. So maybe contact tested, HIV positive, not linked to care, and then we can close this contact. So once you say save contact tracing, you would have saved this, and then once you say save contact tracing and add another, it means that if this person has more than one contact, then you save this contact and then you add another. It will bring for us a fresh window like the one where we have been entering the data, and then we are able to enter details of the next contact. So we save that, and then from there we can be able to save the visit. So once we save the visit, you can see that, okay, maybe I can hand it over to Agava. Thank you so much.
Yeah, Thank you so much, Fatuma, for the wonderful presentation. Now we can open it up for the questions from the people that have been listening in for this whole time. Yeah, so the entire period from now up to the remaining minutes will just be a question, so an answer session. You put up your hand. We have been answering some from the Q&A, but now is the opportunity for you to put up your hand and speak to us. We have Eddie Okwi. You can go first, and then we'll take at least a batch of 3 and we'll respond at once.
This is Eddie. I just wanted to know if HIV data being a longitudinal data, and we want to utilize this for really ensuring that we do effective reporting. Is there a way we will be able now to quickly import data from the Uganda EMR into the digital register so that the continuous engagement and clinical contacts with the client, we are able to update using EMR, using the eRegister? If I want to make the report for the maybe July, September, and I've only dealt with the current encounters in the eRegister, how will I go about this? Maybe just something I wanted to understand from the team. Is there a way we can be able, or maybe a button we are able to click, or maybe when we have picked some data from the EMR, and then we can be able to upload into the eRegister? How are the team going to try to address a longitudinal field study like something to do with the 24-month cohort, 12-month cohort in that regard? Thank you.
Eddie, thank you so much. That is well noted. Yeah, so before we take other questions, Eddie, kindly mute yourself. So colleagues, I want to mention to you that we have this webinar. It's on also tomorrow and the next day. So we have it for 3 days. Today was the first day. So remember to join again tomorrow, and also saturate the link to all the health workers. There is no limit on the scope of who should attend. Everyone should attend. Yeah, so we'll take Jude and Adrigwe. We'll first respond to those 3 questions.
Yeah, thank you so much. I have 2 concerns. In the eRegisters, we're able to actually generate these reports. Last time I tried to generate the 106A quarterly report for facilities that actually attempted to enter data through what she has just taken out through. I was not able to see figures in there. I don't know whether it has been enabled or not. And then secondly, for facilities that have fully transitioned to using eRegisters, are you advising us to tell them to stop using the Uganda EMR or not? Because now these are 2 systems. We cannot continue using the Uganda EMR as well as the eRegisters for ART patients. So you could please give us a final position that, because I saw the same issues being raised in the Biostats WhatsApp group. Any clarification of that on that? Thank you so much.
Thank you, Jude. We can take Fred now. Jude, kindly mute yourself.
Okay,
Fred,
thank you so
submit.
much. I'll take, I think, very few seconds. Are you getting me?
No, Fred, we are not hearing you. You need to start afresh and ask your question.
Hello?
You're not clear. Yes.
Do you get me?
Yes, we can hear you, Fred. Submit and try to be a
Now you
little
get me?
faster.
Thank you so much. Fred from mine is
Fred, we are struggling to hear you. You need to
I
find
just
a
want
better
to
network spot.
inquire whether, like, assuming that the system is off today and maybe after.
Okay, so we have
Do you
failed to
get me
get
now?
Fred. We have failed to get you. You can type
Do
in
you
the
now get
chat.
me?
You can type in the
Hello.
chat. Yes, so
Hello.
Fred, as you type in the chat, we can get Jumulo Nicholas. Fred, we are unable to hear you. Type in the chat. Jumulo, you can unmute and speak to us.
Okay, warm greetings, all members active on this chat. My concern is, maybe you're hearing me. We don't have a provision on the register where we put procedures. For example, we have done surgical toileting and suturing. You want to hear syringe, how are we going to do about that? Then the other issue, when are we going to look at the issue of line listings? Thank you very much.
Okay, thank you. So, Fatima, we can first respond to that batch of questions and then we'll go for another batch.
Thank you, Tim. Thank you, Agaba, for facilitating this. About the importation of Uganda EMR data to the eRegister, I think that is beyond me. I think Dr. Andrew is on this call, should be able to respond to that. But maybe some of the guidance that has come through on top of maybe Dr. Andrew.
I can respond to that.
Okay, no
Yes.
worries.
Okay, so colleagues, where we want to be is that each facility should be running a digital solution. That is our dream as the ministry and as government. Every government process and system should be digitized. So if you're already running an EMR for at least an HIV module component, like the Uganda EMR that we know most of you are running in the art clinics, that is good enough and it is already comprehensive. So you do not need again now to extract data, import it into the eRegister. So the eRegister is a tool that is available for us to be able to use only in the departments or service delivery points where we have no other digital system there, like an EMR. If you don't have an EMR in say OPD and IPD, you use the eRegister. Okay, so we are struggling with the paper tools. In the absence of the paper tools, we brought in the eRegister to bridge that gap. So, but if you have an EMR in the clinic, we are not replacing an EMR with a register. So the register is a smaller component, but the EMR is much more comprehensive. So, and where we want to be in future, we want to have EMRs at each and every facility, each and every service delivery point. So that must be very clear. You also go and preach the same message wherever you're going in your facilities amongst the other health workers, those that are here and those that are not here. So we are not replacing the EMR because that's where we want to be anyway. So if you already have it, well and good, that's good enough. So just use the eRegister in the departments for the modules that are not yet digitized. I hope that is very clear. So it answers both questions from Jude Eyatu and the first guy was asking about importing data into the eRegister. Yes, Fatima, you can proceed and answer the rest.
Thank you, Ben. The other one was about the 106A not being generated the last quarter. Last quarter, 106A was not ready, just to be very open to you. That was not ready as a report, but we knew that actually most of the sites or all the sites were still implementing the Uganda EMR, which was actually actually extracting a report and being reported into the EHMIs. So because of that, we did not have the 106A and concentrated on 105 as well as 033B, so that those reports will be up there and running. But I know that this other quarter, by the end of September, I think this report should be ready because we already have at least dummy report out in the system that we are testing. So by end of September, that will be ready. Then on the section, I think it was Nicholas asking about the section for procedures. One of the things that we need to know is that this system was built for health center 3s as well as health center 2s that do not conduct any minor procedures. So you find that some of those sections had not been input into the eRegister. So maybe Ben can be able to give us an update on that. But that is what I know. That's why some of those had not been input into the eRegister.
Yeah, I think you're very correct, Fatuma. And colleagues, now I also saw it in the chat. I also want to communicate that we have allowed, or we have been guided that health center force that are not running an EMR, that is Clinic Master EFIA, an EMR, I'm referring to a system that has all modules that support the entire facility. If you have a health center that has no EMR, running the entire facility, you're free to use the eRegister, and we should actually support those health center force to quickly get trained, get the user accounts, the biosters that are here, and like Fatuma said, the user accounts are for the entire, not for a single account for the entire facility, but every health worker should have their own user account. Yeah, Fatuma, I wanted you to keep sharing your screen. So we are able to capture some things under IPD. Now that we have also opened it up for health center force that are doing some procedures, we'll consider a few things like that. But Fatuma, for now, you can check under IPD and we see what is catered for, what is provided for currently. If we have some minor procedures there, I&D, yes, inpatient there. Investigation done here. So then there is surgical procedure. So if you do an X-ray, ultrasound scan, you can see we have a number of them there. Then we have surgical procedures there. Next, on the next one, Fatima.
Yeah, here.
Yes. So you're able to see some procedures there. Okay. So those are some of the surgical procedures that are there. So, colleagues, what is important with the eRegister is for you to know the kind of register you need. Most of the things are in there but embedded. You have to just know to try and figure out where to get it. And some are triggered by the selection you make. So you realize that some of those things are catered for. Yeah, so I think we have exhaustively answered to those sets of questions. We can take Tamale Lawrence and Katunji Kenneth in that order. Lawrence, then Katunji Kenneth.
Hello, thank you very much for the presentation. I have a question. We are currently having a challenge as a district with our poor reporting rates. And the guidance was that we use the Verify Reports app to verify. However, some pages of 105 deliberately reject the verification and they say verification error. Kindly try again later, which has really affected our 105 reporting rates for July. Kindly guide us on that. Thank you very much.
Okay, Katunji Kenneth. Kenneth, if you're speaking, we can't hear you. You need to come closer to the device so that we get to hear you.
So when we are entering drugs, the treatment given, we are requesting if they could also put an option of others, just like it is on the part of diagnosis that there is an option of others, then you specify. Because you find most of the clients, you give like 3 drugs, only 1 is in the system. So we are requesting if there is that option of putting other drugs, just like the way it is for diagnosis. Thank you very much.
Okay, so the rest of you colleagues, you can put up your hand when you want to answer. Just to respond to those questions, starting with one from Katunje, the drugs, we are working on getting a comprehensive list of drugs. Right now, it's what we're actually doing as I talk with the pharmacy department. We'll very soon see an updated list of drugs that is more comprehensive. So that is going to be solved very soon. And then I expected that we are asking questions that are strictly related to what they have taught us, what we have been taken through now, so that we don't mix issues. Yeah, we don't want people to be diverted. We are able to answer, but we don't want people to be diverted. Let's try to stick to what we have gone through for today. The other subsequent days, we'll go through the rest of the pending sites and we'll see how it plays out. But just to respond to Lawrence, since he had already asked Lawrence, here, Fatuma can take us through the data entry app. When you click on the apps menu, there is data entry. That app also does the same purpose. It serves the same purpose as the verify reports. So you can select the data set you want to report on, whether it's a 105 data set, 106 or 033B. You can select to the OPD attendance. Yeah, so once you select that, you select the organization unit. And by default, since this is a facility account, you have your facility just for you there, and you select the period, the data for which you want to see, which month, and then nationality. Okay, so it will automatically now give you the report. You see the data is already there. Yeah, but that was just one luck opportunity for Lawrence, who asked before we restricted to make sure we ask for what we have been taught about, what Fatuma has taken us through. Yeah, so we can pick more hands. If you want to speak, you put up a hand, you'll be given an opportunity to speak, to unmute and speak. Lawrence, is that an old hand or a new one? Okay, we have Anena Miriam and the Angwech Patricia. HP, you need to rename your device so that we know the person that is going to talk. Yeah, so Nina and Angwech in that order.
Thank you, presenter and everyone on call. For me, my question would be, there are points where they are asking screen, like screen for HIV, or at some point she was presenting on viral load, and then they want the results there and then. Do they expect the results to be available at that point in time? Or we are inputting, if the person comes for a visit, like today, we are inputting a previous viral load. And then I had an encounter with one of the midwives who was saying, for example, a child comes for immunization, and then we are screening the child. At that point, do we put the mother's previous test, like how do we go about that? Thank you, and back to you.
Okay, Angwech.
Good afternoon. Thank you for this and the opportunity to bring up something. My question was still on the parts of reports. For some facilities, you notice, I don't know where the challenge is coming from, but you notice that when you have an extract or you use the summary part of seeing how many clients have actually been captured, the number is higher than what the facility say, like verified report and then sent it through to the system. So I don't know why that is coming up, where the gap could actually be. An example, in a week, in the entry screen and after probably line listing, have a total of say like 115 clients seen in a week. But then when it comes time for summarizing the report and sending through the weekly report, you would see through that total OPD attendance is just maybe like 70 something. So I just needed clarity on that and how to go around it. Thank you.
Okay, Fatuma, you can respond to those and then we'll take Wandela Simon.
Okay, thank you, Tim. Thank you, Ben. About the viral load results is that, as I was presenting, I was also letting you know that we only enter what has been done on that visit. What have you done for that client? So the expectation is that you have not done a viral load on that visit, so do not enter it. Once you have done it, then that viral load will be tagged to that when the client has.
Wandera, please mute.
Then about the health, the child health, I know we have gone into child health, into the immunization or the child health register where we are asking for the mother's HIV status. Let me just open it here. So when you get in here, of course we see immunization. So I think someone is asking about, so I'm trying to, so there's somewhere where we get the mother's screening for HIV, like here. So once we say mother screened and tested for HIV, then it brings the timing. Is it the first time that we are testing this mother, and what are the results? If the mother is a reattendance and their results are a reattendance result, what is the result? So these registers are based on what we have been documenting in the registers that we have in here. The only difference is that this is an electronic register and the other one was a paper-based register. And actually, when you look at the customization that has been made into the electronic, it is exactly what is appearing in the hard copy tools. So the same way the midwives have been classifying the mother's HIV testing timing, it is just that here we are making sure that we are capturing mothers that are testing for the first time, how many just came in with their babies and actually they are not eligible for a test. Their test is still viable, so we are not going to give them a test. Are they a reattendance, or they are a known client, like known result? We know the result and they are known and the results are still, maybe it's a known negative result, and the mother is not due for another test, or it's a known positive result that we know and the mother will not be tested. And then if it's a reattendance, then we can still test, so that this mother is a reattendance. If you have done an HIV test on that reattendance, then you should say maybe it's a reattendance and the results are negative. So the same way we have been documenting, and one of the things that we need to advise the health workers is that the electronic system has not, actually it has just replaced the paper that we were writing in, and now we are writing in the computer. What we are writing on the paper, we're actually inputting it into the computer, so that they don't think that this is now a new development that has come through. I think that is what I can talk about the HIV testing. Then about the reports, I think this is something that we need to, investigate, because we know that we have tested as much as possible. We have tested these reports, and we do not expect the reports that are being generated through the line is to be different from the reports that are being generated from the aggregate report. Maybe one of the things that we need to know is that as we look at, let me just get back here. As we look at maybe the dashboard here, we can say that yes, we have registered these so many patients, but of course, these are clients that are coming from the different entry points. We also need to be mindful of that. Yes, we might think that all these are OPD patients, but some of them are not OPD patients. But this is something that we can look through, and then we make the report better if the report has a few of those discrepancies. We can be able to air them out, and then but we can investigate that further. So on offline, I think, Patricia, we shall have to have a one-on-one so that we go through this, and then we see, in case there's a system glitch, then we should be able to sort it out. If it is a problem on your side, then we should also be able to highlight it, and then we rectify it accordingly. I think that is it from me, Chair.
Okay, thank you, facilitator. Colleagues, the issues will keep coming up, but we encourage you to open them up to your regional coordinators and the biostats. Let's not sit on problems. Just make sure you raise it as it comes up. We have very many channels of support available. Let's not sit on problems. Raise it to the biostat, raise it to the Minister of Health trainer that trained you, and the regional coordinators and the IP also. Yeah, so Simon and Akiso in that order. So we can take those questions, Simon and Akiso.
My challenge, am I on? Hello?
We can hear you, Simon, proceed.
My challenge is about the signs and symptoms of eye diseases. I've tried to check and I couldn't get any. However, in the diagnosis, you see bacterial conjunctivitis, allergic, and the rest. Then two, how can I generate a dispensing log? Because like most facilities have stopped using dispensing logs for drugs. Then three is with the HIV clients. Is it only for the new clients? What happens to the continuing clients? How do we document them? Like for the continuing clients. Thank you.
Akiso?
Thank you so much, James Akiso. Mine is one on registering or updating the art clients. I'm seeing like for every visit, you need to update the baseline information, like the baseline CD4, the art initiation date, baseline regimen. But I thought since those variables don't change over time, is it possible to have them like every time I'm updating, they are auto-reflected instead of having to be captured each and every time that the client is visiting? And then also still my submission on the Uganda EMR versus the digital register for specifically the art clients. Yes, my only worry is that the support to the Uganda EMR, I think, has mostly been hinged to the IP. A case in point, like in my district, I have like 2 or 3 facilities where almost every 2 to 3 months, the computers for Uganda EMR fail and they have to be carried to the IP to be fixed, and then they again come back. So within that time, you find that a lot of backlog is accumulated. There's a lot of back and forth. And as a district, we still don't have someone who is able to offer that kind of support. Now in an era where even the IP is getting thin on ground, how best are we going to make sure that the Uganda EMR is continuously well updated? That's why we're thinking of the view. Now, since we are the eRegister looks to be very robust and the biostats are really on ground and have been very well trained, why don't we adopt using eRegisters for all the services as opposed to having the Uganda EMR and then digital registers for other service points? Thank you.
Okay, so Vincent, and then we can respond at once. Dr. Andrew, something keeps coming to your screen. We want you to join as a panelist, kindly accept. Yes, Vincent Ota, if you can ask your question and we proceed. Okay, Fatuma, I think we can respond to those sets of questions.
Yeah, so thank you, Tim, for raising all these concerns about Simon. Signs and symptoms of eye conditions is that, as we all know, that we have been updating these signs and symptoms as feedback has been coming through. So maybe we need now to get to the, I don't know which department is this, but I think it is the clinical department, to give us additional signs and symptoms for the eye conditions so that we add them onto the list. Yeah, then secondly, about the documentation of continuing clients, I know that as I was registering this client, I was also hinting onto registration of the client that is old. So let me say we have this Nantongo has come back. So I just say add new visit here. Then I click the date of today, since it is the one that I have. Then when I click on ART, because Nantong is our ART client, So it will display this, okay, we shall fill in all this. But when you go to ART, that's why we have visit type. So when you have visit type here, it is asking whether this client is new or is a revisit. So if this client is a revisit, then you will select revisit and then you continue with the rest of the other things. And then when it comes to the drugs down here, there's where they are asking for whether this is a new client on these drugs or is a current or is maintained or switched, something like that. I'm trying to get, it only displays when the, okay, this regimen status, it only comes when the treatment line has been selected. Once I select a treatment line here, once I've not selected it, it does not display the status for the regimen. So here, this is where we also say this is a current client, because here this will enable us to know those that are current on that regimen, that are continuing on that regimen, or how many have been switched, how many have been substituted within that quarter. So for the reattendance, we just go here and click on reattendance and then continue with the same menu for the ART clients. Then still, I think for James, I think he was asking about these other, because now you can see here, I selected Nantongo. I clicked on ART as a service type. You can see that the ART start date has been auto-selected from the previous visit. Okay, yes, she visited today, but you can see that now I cannot enter something to do with the ART visit. So some of these capabilities have been input into the system, but I know that maybe we need to just work on the baseline information, maybe like here, baseline CD4, then we need to also input it there so that it is also auto-generated, as we see here, the ART start date being auto-generated from the previous visit. So this can be worked on. So it is something that we can also auto-generate, like it has been auto-generated for this. Then support for Uganda EMR hinged to the IP, and then its continuity, and then how we ensure that maybe we migrate all of us to the eRegister, is that just like the beginning, I know that Dr. Andrew gave us a history on how this eRegister came through. We also need to be very mindful. The eRegister is like we are saying, okay, it's not an EMR like the Uganda EMR for now. So for now that the Uganda EMR still has support, we should continue with the Uganda EMR. Then as Ministry of Health also forges the way forward, as we see that maybe the eRegister will be substantive enough to also accommodate what has been happening in the Uganda EMR. But for now, I think guidance is that let's just continue. We also understand whatever is happening within the country. Also, we understand and we know what is happening and the thinness of the IPs on the ground. But since you're still there, kindly just support appropriately, as also the ministry is also devising means on how to see how we maybe have these clients maybe migrated to Clinic Master or migrated to any other ART systems that are out there, so that we have them into one comprehensive system. I think that is all that I can say about what has been hinted on. Back to you, Chair.
Okay, thank you, Fatuma. We just have one hand up, Letter Henry, and we are left with 2 minutes. So after Letter, we respond immediately and we give it over to Dr. Anu to give the closing remarks. Yes, Letter, you can unmute and speak to us.
Thank you so much. This is Letter Henry from Soroti. I would like to inquire or seek clarity on two areas. One is that on that area of medicine and supplies, whereby you find maybe a clinician has prescribed Piriton, and on the paper or medical form, it is indicated maybe as the patient is supposed to swallow maybe Piriton like 4 grams, that is 2 BD, or 1 BD for like 3 days, but the system is saying the system only requires us to put the quantity dispensed and the quantity prescribed. And now in a scenario where we are moving away from the paperwork to electronic, if this patient is moving to the pharmacy, whereby the pharmacy is far away from, or let me say in another room from where the clinical room is, won't it disturb the dispenser on how to advise the patient on how to swallow the drugs? That is one. Two, now in our setting where we are, you find we have 2 registers in OPD because we have prisoners to treat, of which you cannot use the same OPD register to have all those prisoners and staff in one register, no. So you will need to have we have 2 registers. One is for the community and staff, and then one is for the prisoners. So the question is, want you to bring confusion like when you are awarding the OPD numbers? Thank you so much.
Okay. Fatuma, you can respond to that and then we close it off for the day.
Yeah, so thank you so much, Henry. About the medication scenario of giving alternative medication, I think one of the things that we need to do at the clinic is that as we start the clinic, we need to be aware of what we have within the clinic. And ideally, if we are dispensing or we are prescribing something that is not in the clinic, of course, by the time someone gets off gets to the window, we know that that is not there. So we shall be able to put what we have as prescribed, and then we shall not dispense, and then tell the person that actually the doctor has given you ABCD, but it is out of stock. So kindly go to the pharmacy and buy. So, but to reduce on some of those is that as we start the clinic, we need to know what do we have in stock and what don't we have in stock, because that also helps the dispensary or the dispenser to know how we are going to dispense accordingly. Or the clinic team will also be able to know how much can we be able to dispense, because what I know is that in the HIV clinic, at least for them, they are able to sit and say, we know we are running short of this. So maybe for all the patients that are going to come that are on this regimen, we are going to give them maybe 1 month stock as we wait for the other stock, or wait for NMS to supply. So I think that is all that I can say about the medication. But also previous, we used to have a window where I would have prescribed as well as dispensed. Would click on the same medication for prescription, and then when someone goes to the dispensary, they would also search for the same medication, put it there, and also put the number that has been dispensed. And some of the feedback that came through was that this is double work, and that's why that was pulled off the medication window. I don't know whether now we need to bring it back or we just need to maintain as is. Then for prisoners and community registers is that please note that the system that we are working with, even when you look at the categorization of the clients, we have special categories. So that is where we shall have the prisoners categorized. So the thing is that, yes, the other side, we have been dealing with paper registers. Now we are going to be dealing with the system. So we are going to treat all clients equally. So I don't know whether Uganda prisons wants maybe a special something for them, because here in the client profile, we do not have special categories in here, but the special categories have been categorized based on the services where these special categories had been classified, even in the registers where the services were being documented. So I think on that, I think we need to see if we need to also bring it here on the registration page, so that we categorize the client from registration. But remember, for registration, when we register a client as a prisoner, they're not going to be a prisoner forever. but this data will remain in the system. So those are some of the things that actually, even when we did the Uganda Prison Services training, the team from Uganda Prisons actually was trying as much as possible to tell people that please do not categorize people as prisoners, because today someone is a prisoner, the next time they are not going to be a prisoner, and yet you have already recorded them, and that is going to be on their record forever and ever. So I think these are discussions that need to be held with the Uganda prisons as well as maybe MOH, so that a conclusion can be made on that. But in the registration, let's just register the clients normally as we register them for a service, because as they come for a service, we expect that they have come for a service, they are all equal despite where they are coming from. Over and back to you, Chair. I think that is all that I can say about.
Yeah, thank you very much, Fatuma. And just to pick it on from where you stopped. So the prisoners team, it is just about uniquely identifying your clients. I know that's why you register the prisoners separately and the officers alone. So just at the OPD number, you can innovate ways of adding like a P before you add the actual OPD number, so that you have P01, P05, or any other innovative way, so that when you're doing a line list or extracting a report, you can know that these people are with a prefix of P are prisoners. Yeah, that is it. Then about letter, kindly mute. Letter, kindly mute. So then I also wanted to speak about the drugs. The drugs section is being revised. We are going to add in a few other elements to help you make more sense and also update the drug list. So I hope that is very clear. And then another area that I had people talking a lot about in this meeting is around the HIV clinic. So you realize there are some things that are one of like the baseline information, and those that we keep capturing at every encounter, yeah? So we want to put in some other elements, and I want to keep telling you that this system, we keep improving as we use it. So we want to put in some components of visit type, where we have new, and then we have follow-up visit. When it's a new visit, you can strictly see baseline information that is captured when someone comes in for the first time. So yes, so you see we have this new revisit. So we want to tag all the data elements to these two, so that if it is a new client, you can only see things related to the baseline information. Then the revisit can also allow us, if you can scroll up a bit, Fatuma, to look at things like viral load and other things that you get. Yes, when you're supposed, you see now like this viral load results. So all this should come on a revisit, not on the first visit. So for the new visit, we would not expect to be picking certain things like viral load and so on and so forth. Yeah, so colleagues, I want to thank you very much for being patient up to this time and being active participants in our webinar. Like I told you, we're having it again tomorrow and the next day. So I want us to end it here. We intend to be time conscious during these webinars. Allow me now to invite, I don't know if Dr. Andrew is still there. Unfortunately, Dr. Andrew has dropped off the call. Yeah, but colleagues, want to thank you for being active and for paying attention. And we ask you to saturate this information with the rest of the health workers, so that tomorrow and the subsequent days, they don't miss these webinar series, because they are targeting you and they are for you. Thank you very much. Our facilitator, Fatuma, thank you so much. And Michael, we wish you a blessed evening. See you again tomorrow at 2. The meeting is adjourned.
Thank you. Bye-bye.